Now, this is underappreciated, maybe not so much now, but it was recently. First of all, if you look at the distribution of LPA, it's not like a little bell-shaped curve. It's really, most people have low levels. Normal is considered 30 or less. And then there's some people that have borderline levels between 30 and 50. And then you have this sort of 20, 30% that have the high levels. So just to take you through the math, this is a US laboratory database, 530,000 patients. LPA was measured with the DENCA assay, which is felt to be the best one to date. And if you ask the question, how many patients have levels above normal? In this database, it was 35%. So if you extrapolate to the US, that's 112 million people in the US that have what is considered an abnormal LPA level. If you extrapolate globally, it's over 2 billion. And so if you just use 60, which is twice normal, you see here there are just staggering numbers of patients that have high LPA level that we really haven't, we may only know about 1 or 2% of these that have actually been measured. So this field is just going to extrapolate out as we get therapies. All these patients are going to have to be identified, and then we have to figure out how to manage them. Now, I'm not going to spend a lot of time on the pathophysiology, but it's very well accepted now at the primary care setting, meaning people have not had an event. There are 3 levels of evidence for risk: meta-analyses, Mendelian randomization, genome-wide association. And if you look at these, this relationship to risk is fairly flat until you get to about 30 milligrams per deciliter. And then it seems to be linear with risk and levels. So you can look at this at the genetic level, or you can look at this at the plasma level. And so this is where some of the data comes from about what is normal and what is normal.